I'd also like to welcome all Aboriginal and Torres Strait Islander people present here today. I would like to welcome the general public here, and no doubt there's a few of you, the fellow Barwon Health board members who are sitting in the front row, several of the directors. I would like to also welcome Barwon Health Foundation board members and Barwon Health Foundation Future Fund directors. We have three groups there. Also people from the Gala Appeal Committee who are here tonight, thank you very much. People from the Barwon Health Executive and all of the staff, nearly 7,000 employees, not all here tonight, but I don't think we could fit them in. And a representation from our volunteers, and we have around about 1,300 volunteers. So thank you very much for coming, and we truly welcome you and thank you for your presence. We have apologies from several groups, several people, parliamentarians. There's apologies from Gail Tierney, MP, Member for Western Victoria, the Honourable Jala Pulford, Member for Western Victoria, Minister for Agriculture and Minister for Regional Development, a very busy lady. Andrew Katos, Member for South Barwon, the Honourable John Erin, MP, Member for Lara, Minister for Tourism and Major Events, Minister for Sport, Minister for Veterans, another busy person. And finally, from the State Government, the Honourable Lisa Neville, MP, Member for Bellarine, Minister for Police. They're all apologies. We have apologies from two councillors, newly appointed councillors, Stephanie Asher, City of Greater Geelong Council, of course, and Chris Potter, Colac, Otway Shire. Other apologies come from Professor Dan Hollander, the Vice-Chancellor at Deakin University, and Rebecca Casson, the CEO of the Committee for Geelong. Well, this is my first annual meeting for Barwon Health as Board Chair. Tonight is an opportunity to acknowledge past Board Chair, and I'd like to do this first off, Dr. John Stecklenburg, for his leadership of Barwon Health over the past 6 years. Under his leadership, the Board and the Executive went through one of the most intensive programs of capital works in the history of Barwon Health, and a heightened focus of delivering safe, consumer-centred care. John is widely respected in Geelong, and his significant contribution to Barwon Health will be a lasting legacy. I would also like to acknowledge the contribution made by Professor Belinda Moyes in embedding clinical leadership at Barwon Health, and Associate Professor Alex Cockram for her guidance in leading Barwon Health over about a 3-month period before handing over to Professor Ruth Salem in August. By way of an outline of the evening's proceedings, we will commence with the CEO, Professor Ruth Salem, providing us with an overview of the 2016 and 2017 financial year performance. Once Ruth finishes speaking, we will move on to the open access board meeting, where you will hear from a series of speakers on the topic of end-of-life care and voluntary assisted dying, defining a good death, followed by a panel discussion facilitated by Dr. Nick Simpson. Ladies and gentlemen, it gives me great pleasure to introduce Professor Ruth Salem to you.
Thank you very much, Brian. I guess I'd like to start first by acknowledging the traditional owners of the land, the Wadawurrung people of the Kulin Nation. Pay my respects to their elders past and present. I'd like to welcome all Aboriginal and Torres Strait Islanders. Ladies and gentlemen, colleagues, volunteers, board members, welcome to the Barwon Health annual general meeting. As you know, I've only been at Barwon Health for a relatively short time, but one of the things that I have found is that the people here are absolutely committed to what they do. And truly, we have one of the highest standards. Now, as you can imagine, these annual general meetings are very much scripted, and we have things that we need to say. But at 10:15 this morning came through an email that I would really like to share with you. It was from a patient's mother, and this is what she wrote to us. So she went by saying, "I want to share with you my family experience with Alan David Lodge. Unfortunately, Mum died in October. First, your Num Jess is outstanding. Her leadership shined through to all of the staff. Nothing was ever too much. If I could work out how I could steal her, I would. The care Mum received was amongst the best I have seen in my 30 years of nursing. The patient's mother was a nurse herself. Mum went into care with multiple pressure injuries on her legs, which repeatedly got infected, and we were always facing amputation. Through the super care of all the team, Mum died whole and for the first time in 5 years had no pressure injuries or blemishes. The palliative care given to her, and more importantly to my father and sister in the last days of her life, was amazing. I also need to highlight Corinne's, your billing manager. Who would think that someone would talk about a billing manager? She's exceptional. Every question I had about finances associated with mum care, she helped me solve. Her empathetic approach is amazing, and I never felt a burden or a pain, even though I am sure I was. I guess what I'm saying is that I want you to know that I am so grateful for choosing your organisation to care for mum, and would appreciate it if you could share this with your executive and senior leadership team. I wanted to share this with all of you because these are the sort of things that our staff do day in and day out. As I have said, the organisation is committed, and together with consumers, with our volunteers, with all of our staff, we have a vision of building a healthier community for this area for Barwon. I'm also impressed with the role that our consumers play in the organisation, endeavouring to reach higher goals. Their ability to engage with the broader community is absolutely something that we need to commend. In the objective of Public Health Service to deliver a break-even budget every financial year, we do have challenges. We have to make decisions. But I'm pleased to report that we have had a positive finish to our 2016-17 financial year. And one of the things that I have to acknowledge is I have only been in the organisation for some 4 months. It is those who have preceded me that have done an absolutely amazing effort, and it is the staff, and it is all of those others, not myself, who have done an absolutely amazing effort to take us from a deficit of 12.8 million to a modest surplus in the 2016-17 budget. Absolutely all staff are to be commended for the role they have played in delivering such a significant result. You might ask yourself, how have they done it? Is it about slash and burn? But it wasn't. It was about close monitoring of savings plans, which resulted in review of services and supply contracts for efficiencies. There was increased activity across the organisation, resulting in increased earnings, but also in increased ability to service our community. There was realignment of our asset base through the gifts that we were given through residential properties, and where we did not need those properties, that those properties were put to better work. We worked hard to create a strong, stable workforce. By placing more staff on permanent contracts, we were able to make savings out of decreasing agency costs, but what we were able to do was to create jobs, permanent jobs, for the residents and for the staff in this area. And that, I think, is a great thing. We have increased our full-time staffing by about 100 FTE, but in that same period, we were able to decrease our costs by decreasing our agency. In the face of increasing demand, we have exceeded the elective surgery waiting list targets. We have reduced our waiting list, whilst we would love the waiting list to be zero, but we have reduced our waiting list to 1,200 against a predicted expectation of having 1,250. What this has meant is that we have been able to put through all our various undertakings to be able to operate and give services to 21,326 people in the community. We have also been able to work with our partners, Epworth Health, in delivering some of these services. A number of eligible patients have been able to access treatment within Epworth and keeping our waiting list down, but also ensuring that all of our patients are being given access as much as possible to the surgery that they require. Our performance was also aided by alignment of beds with service model. This alignment has seen greater efficiency on how we work and improve the patient experience and quality of care. It has also undoubtedly been an exceptionally busy year for our emergency department. Whilst many of you would have seen that we have had periods of unprecedented growth in our emergency department, it has been absolutely challenging, and this has been due to factors such as that our department is considered to be of the highest quality. People don't want to go to private, they want to come to Barwon Health. Also, we have had the flu, and again, we have seen unprecedented numbers. We have treated close to 70,000 people in our emergency department. Year on year, we have seen growth, and overall, we have treated more than 2,200 people more this year than in previous years, and we have seen an increased growth of 11% over the last 5 years. The growth in attendance to emergency department has grown steadily, with the trend continuing into 2017-18. We are seeing regular presentation above 240 patients a day. These are really high numbers, and they are some of the highest of the Victorian Health Services. We have seen a growing trend of high acuity patients needing more complex care and having experienced no drop in demand due to 2 private emergency departments in our region. It is a real credit to our emergency department clinicians that the quality of care that the region sees coming from this department is so much so that everybody wants to come to our department. The flow of patients has been aided by new models of care, including the opening of emergency department short stay unit for adults and for our paediatric short stay. These models of care have allowed us to create for patients an environment which is away from the usual business of the emergency department and gives them specialised care in our short stay units. The increased elective surgery cases and increased numbers of presentation to the emergency department has also had flow-on effects to our outpatient presentations. There is no doubt that our outpatient presentations have continued to grow, and this has again been year on year, the number of patients requiring outpatients has increased. This pattern has extended to the care undertaken. This is a pattern that extends to the care undertaken through our network of community health centres. We have also seen increased demand for our dental health services, and those of you who were present at our quality awards last night, you would have heard the great work that is done by our dental services. The great many initiatives that our dental services have done has been recognised not only internally, but also at the Victorian Healthcare Awards, where the dental services had a number of nominations and high recommendations. Our outreach program for dentals are growing from strength to strength, and we have a van that gives regular visits to towns in the region. Caring for our community also extends to our reputation as a health promotion health service. As a foundation member of the Victorian Network of Smoke-Free Healthcare Services, we have continued to lead the way in creating a smoke-free environment. We have also started the year by being the first public health service to phase out sugary carbonated drinks, and we have done this in collaboration with our regional partners. The Barwon South West region has collectively brought on the reduction in and elimination of sugary carbonated drinks within our hospitals. And this move was certainly welcome and supported by the Department of Health and our health service. And this is a significant step in promoting the message to reduce sugar consumption. Our research activities also continue to grow. So again, for those of you who have been present during the Research Week, you would have seen the large number of presentations that were made in posters during that period. Over the last year, we have had more than 480 peer-reviewed journal articles that were produced by our researchers, and this represents a 10% increase over previous years. We have also increased our research funding through NHMRC and other grants, and this year it was over $7 million. The growth in research is a testament to the calibre of staff at Barwon Health and the growing culture of inquiry. In order to provide quality care, we need to train not only the next generation of healthcare workers, but also ensure ongoing access to training and education in the overall environment. And this is certainly supported through our whole organisation. Our continued growth in student and training activity reflects the rich clinical learning environment we offer and the commitment and enthusiasm of our education and clinical supervisors. And certainly some of you might know that we had 100% pass rate for our physicians this year, and that is a totally amazing result considering these are specialist exams where the average pass rate is around about 50%. We continue to strengthen our partnerships with Deakin University, as well as other education bodies, including the Gordon. We have also signed an MOU with the College of Surgeons, and that's an important first step in ensuring that we have the culture that we want within the organisation of Barwon Health. The signing of the MOU with the college documented our shared commitment to effective collaboration and quality education, but also how we will work together in partnership through our values. We're also grateful to the state government. The state government has continued to support Barwon Health, and our aged care facilities were improved with the refurbishment of Alan David Lodge, and also commenced to better improve the internal and external environment for residents over the next 2 years. There are going to be further refurbishments at Percy Baxter Lodge, at the McKellar Centre in North Geelong. The Percy Baxter Lodge upgrade has been a $2 million investment and was done in consultation with the residents. And the residents were able to collaborate with the architects and with the refurbishment requirements, and this has included the replacement of carpets, new paintwork, improved lighting. This refurbishment represented an opportunity for Aboriginal Health Team with commissioned artwork and a large mural done with school children representing the local history and Indigenous culture of our region. We also launched a Sunrise Centre, GMHBA Stadium, at the end of the financial year. This facility made possible due to the generous support and sponsorship from the TAC and the Geelong Football Club. There is also work on the renal home training project, and this has commenced, and we are very thankful to the generous funding from the Department of Health and Human Services for this also. The new facility will replace the ageing Rotary House and will feature renal, chairs, education, consulting and examination rooms, and will greatly improve service provisions for renal patients in a fully integrated facility. And integration is so important, and I'm sure all of you realise that. We are now in the second half of our strategic plan that puts the consumers at the forefront. We need to work through our strategic plans and revise them, but I can assure you the consumers at the forefront will remain and always will be one of the pillars of our strategic plan. An occasion as today could not go without thanking our volunteers. Volunteers continue to create an impact throughout our service. They are often the first people that the visitors to our organisation get exposed to. We are increasing the number of volunteers in terms of we're going to have greeters at our entrances to be able to better be able to integrate and be able to facilitate those coming to our organisation. We currently have 1,300 volunteers, and we also have a waiting list. I think we are the only health service that has a waiting list for volunteers. It just shows the great community spirit that we are so grateful to have at Barwon Health. So I would like to formally thank all the volunteers who support us for many and varied roles, and certainly we couldn't do without you. Thank you. Our fundraising has continued to prosper, and this year has focused on securing support for key flagship medical research programs at Barwon Health, with a focus on child health research through Barwon Health Infant Study and the continued and world-class research in the area of mental health, healthy ageing, emerging infant disease centre and cancer. Our community support continues to grow and is annually recognised at key events such as the Gala and Run Geelong. And certainly I was told that the Gala has been going on for nearly 100 years, and it's something that is very much the fabric of Geelong. I certainly participated in the Run Geelong, and it was for the first time, and I'm going to get a lot fitter next time. I wasn't fit enough. I would like to acknowledge and thank our Chair of the Board, Mr Brian Cook, all of our board members, both from the Barwon Health Board, our Foundation Board and the Future Fund Board. I would also like to thank our executive and clinical leaders for their support and the hard work, and all our staff who have contributed to making this a very successful year. And thank you all for being part of this. I would like to now hand over to Brian for the continuing of this. Thank you very much.
A couple of things I should have mentioned as people walked in. is make sure you sign your name on the sheet near the door. It's a regulatory requirement, apparently, so make sure you do that, please. And also, Kate Biddy is here, who put together a fantastic annual report, and this summary. Now, you can either read the 200 pages or the 3 pages. I'll be taking this one home, so thanks for doing that, Kate. Any questions for Ruth in relation to the operations of the hospital? Or Barwon Health, sorry. If there is none, that is good. Thanks, Ruth. I think you can sit down. I would now like to declare the annual meeting closed. It's now time for us to move on to the open access board meeting. These meetings are held annually and are designed to foster interaction between boards and the community. The aim of this meeting is to raise awareness and understanding of Barwon Health and provide a forum for information sharing. It is the community's opportunity to participate in decision-making processes and gain an understanding of the rationale, context and environment for board plans and decisions. Tonight, as previously mentioned, you will be hearing from a series of speakers on the topic of end-of-life care and voluntary assisted dying, defining a good death. Could I please ask our panel of 3 speakers to come to the stage? End-of-life care and voluntary assisted dying has dominated the media over the past couple of months and was also a topic of discussion at the recent Barwon Health Deakin University Research Week, where a panel discussion was held on this topic. Tonight is not dissimilar in its approach, in that we will have a facilitated discussion with Dr. Nick Simpson. Stand up, Dr. Nick Simpson, if you don't know him. Thanks for doing this for us, Doctor. Thank you very much. He'll be leading the panellists, including the Associate Professor Charlie Cork. Charlie, thank you. Speaking on a personal experience with a family member with voluntary assisted dying. Rick Milner, GP. Rick, stand up, thank you. And voluntary assisted dying advocate Will Talk on his personal journey as detailed in a recent article in the Geelong Advertiser. And that was really interesting, really interesting. Keith Fagg, the past Geelong Mayor and current Barwon Health volunteer, will be speaking about his family's experience with the deaths of his parents who had advanced care plans. So thank you, Charlie, Rick and Keith. And I'll hand over now to you, Nick, to facilitate this panel. Thank you very much.
Thank you, Brian. I would also like to acknowledge the traditional owners of the land and pay my respects to the elders, both past and present. And I'd like to welcome all Aboriginal and Torres Strait Islander people who are present today. And it is a great pleasure to be here to facilitate this panel discussion tonight with 3 widely respected members of the Geelong community. It's very appropriate that, having heard from Ruth and Brian the progress that Barwon Health has made in meeting the needs of the community, that we should talk about a topic of great importance within that community, that which constitutes a good death. I must admit I spend a lot more time listening to this topic than I do talking about it. I work in a specialty where up to 10% of the people that I look after will die before they leave hospital, and so looking after them and their families up to and beyond the point of death is of great importance. This means that myself and my colleagues have a unique opportunity to not only help people get better, but also to listen to their hopes and fears in the last hours, days, and months of their lives. Though we aim in medicine to reduce the burden of disease, and we have halved death rates from illnesses like sepsis over the course of the last 2 decades, our overall mortality still sits at 100%, and death is still something that we can all expect to experience. This week, Victoria became the first state in Australia to legalise assisted dying for the terminally ill. There has been vigorous community debate and parliamentary debate, with great passion on either side. At times, the debate has been divisive, but perhaps it's also a good time to consider the things that bind us together. When we ask people, there are very different concepts of what a good death might look like, calm or controlled, heroic or even a struggle. In the words of Dylan Thomas, do not go gentle into that good night. Old age should burn and rage at close of day. Rage, rage against the dying of the light. And yet common themes prevail, like the wish to be recognised as an autonomous person, to have individual needs met when dying. The opportunity to consider death unites us and allows us to access the meaningful parts of our lives. Considering individual values and hopes allows us to tailor treatment at the end of life. In other words, to lead the fullest quality life right up to the end of it. And tonight you'll hear from some respected clinicians and unique members of the Geelong community. Their professional expertise is impressive, but the experiences they will share are personal. And by sharing their perspective, perhaps we can reflect on our own experiences of death and dying, and most importantly, what matters to us about living. We're going to hear a brief talk from each of the speakers, and then there will be an opportunity to ask questions. I'm sure that there will be a large amount of thought and discussion, and so I'd ask both our panellists and our questioners to be as succinct as possible. I'd like to first of all introduce Dr. Rick Milner. Rick has been a GP in the region for more than 30 years and was recently named GP of the Year at the RAC GP Awards. He has extensive experience as a GP Registrar Supervisor, and he's been recognised for his work in sexual health services and providing GP services to prisons for over 20 years. His work has been recognised with a Community Award from the Victorian AIDS Council and a past Clinical Excellence Award from Barwon Health. Rick is also on the board of the Western Victoria Primary Healthcare Network. He is currently on extended leave. And I'll pass over to you, Rick.
Thank you very much. I'll just open this. About in end of February, early March, I had chest pain and I went to A&E, but I went to the other A&E. They were good too. Through the investigations, there were some holes and sclerotic lesions in my spine, and through a series of processes, I was found to have pretty extensive metastatic cancer, which was shocking and frightening. But the first thing I did once I'd got off the floor was I actually went to see my GP, who's in this room, and she was fabulous. Actually, I got her to come and see me. And the reason I wanted to speak to her is I wanted to get the end bit sorted before I concentrated about what treatment options. Because the fearful bit for me wasn't treatment. That's just treatment options are it's an algorithm you go through, you make choices. But the end, the sticky bit at the end, is what frightened me, because I'd been involved in looking after people at the sticky bit for a long time. So I feel that because I'm a doctor and I have some knowledge and have access to all sorts of gear I could get, I can manage my own bit at the sticky end. But if I stuffed it up, I asked my GP would she keep me comfortable, and she said she would. So I think what's happened is the state is following that approach. By having the sticky bit at the end sorted, or options sorted for patients, they can get on with sorting out the rest of the things that they need to do. You may think, well, okay, I'm a doctor, I might think differently to most people about this. And one of my medical power of attorney and my advanced care directive medical power of attorney, I went and discussed this with him, and he thought I was weird. But he thinks I think a little bit differently to most patients. I don't agree. I think I thought that way earlier. Most people get to that decision eventually where they get worried about that, but about the end. But everybody does worry about the end, and this legislation allows less worry. Now, the coroner has reported there are quite a large number of people with terminal care who attempt to kill themselves and often don't do it successfully. Sometimes they do. And I think that's really sad, and nobody wants that. And I see this law reform as similar to abortion law reform. We know that through every jurisdiction in the world, the easier you make it to have terminations of pregnancy, the less occur. And I would suspect that now this law's in place, there will wind up with less people taking it up, not more, because it allows the conversation to occur. So I'll tell you about a patient that I looked after a long time ago who had a huge impact on me in this issue. He was a 40-something-year-old man with HIV, haemophilia and hepatitis C. He'd had a big bleed in his brain and was taken to the Alfred where he was evacuated. He would then return to Geelong and I saw him in the ward and explained that he was in a bit of trouble. I saw him again at home. He had vaguely recollected our conversation and he said, "I'm stuffed, aren't I?" He actually didn't say that, I'm being nice. He then asked me to kill him. I attempted to explore the reasons why, and he told me he was worried about being a burden to his family. He had terrible pain in his elbow because when he'd been nursed in the Centre of Excellence, they hadn't nursed him very well, and he'd had pressure sores and all sorts of things on his elbow. And he had ongoing significant pain from an entrapped nerve. He had a whole lot of things wrong with him. So we came to an agreement that he would give me 3 weeks to sort those things out. And if I didn't sort it out, I agreed that I would help him exit. And I said that he asked, "How would you do that?" And I said, "I'll just withdraw the things that are keeping you alive and I will give you enough sedation that you're comfortable and you can die." We both cried. And I said to him that if this is a tough thing to do, in 3 weeks' time I'll come and talk to you again and you just give me the nod. You don't have to go through this brutally hard stuff if you don't want to. So we worked really hard. A plastic surgeon here, Peter Callan, operated through Hep C, HIV, blood everywhere, fixed his elbow up. He had a whole lot of things done. I saw him twice a week and he was beginning to improve a bit. I saw him at home. And in 3 weeks' time I went back to see him and he was sitting in his wheelchair with his head back. I thought, oh no, he's had another bleed into his brain. And I said, "Are you all right?" And he said, "Yeah, I'm fine. I'm just too scared to nod." With a few more expletives. He died 8 months later. He had good quality of life. So there's this, at the moment there seems to be in this argument about this bill, polarising views that you can either have good palliative care or you can have voluntary assisted dying. Of course you need both. And I think by me saying that I would help this man, that legitimised him telling me what his problems were, and that's how we sorted these things out. I think that the state acknowledging that there is no such thing as perfect palliative care, there's no such thing as any perfect medical procedure, there are always things that can't be done. This allows people to have autonomy and make their own decisions. There are some problems with this bill, however. There's this rule that you've got to have a terminal illness and with a life expectancy of less than 6 months. Projecting life expectancy is terrible. You can never be accurate. It's okay to say a group has got a median survival of 6 months or 12 months, but for an individual it doesn't mean much. That's a problem. The other thing is the bill often... There's a lot of stuff in that bill to protect people because everyone's terrified that relatives are going to want people to be killed to get their money. In all my life as a doctor, I've seen enormous pressure the other way. So patients who say, "Oh, I've had enough, I don't want to take that crap anymore, I don't want any more chemo, I don't want any more of that stuff," they get pressured by their relatives, "Come on, have a go, try this, do that." So the pressure is always the other way, not that way. I have seen on several occasions when someone is terminally distressed, I've seen loved ones saying, "Can't we do something about this to relieve that?" But that's not the same as the fears that were put around about this bill, that people are going to be running around killing all their relatives off. It's complete nonsense. It's fear-mongering. Victoria has had a tradition of innovative legislative change with smoking, with abortion law, with seat belts, with fluoridation, and this is another one of those bills that all the fear-mongering will never come to light. This is good public policy to allow people to have better deaths. Thank you.
Thank you, Rick, for that unique personal perspective, enormous personal and professional experience in the area. I'd like to next introduce Keith Fagg. And Keith is a face that is known to many in Geelong with a name that is synonymous with the hardware industry due to his family having the Faggs Mitre 10 stores. He is also more recently known as the first directly elected Mayor of Geelong. He has an extensive history in community groups, is a Rotary Paul Harris Fellow and one of the original volunteers in the award-winning Dignity Therapy program. I've grown to know Keith more recently in his role as a volunteer simulated patient at the Simulation Centre, and I can tell you that the image of Keith running around in his patient gown and his underpants is one that's very difficult to get out of your mind. So I'm very glad that you wore a suit tonight, Keith. Welcome, Keith, back.
Thank you, Nick, in that role with the medical students, which is a lot of fun, by the way. I've had everything from pericarditis to UTIs and everything else, and DVTs and everything. So it's a privilege to do that work with the fourth year students at Deakin. I'm here tonight to speak briefly about advanced care planning and the death of my parents. And it's fair to say that probably up to 4 years ago, I didn't even know what the term advanced care planning was. I thought it was something to do with something you did, how someone was looked after in their home or something like that. I didn't understand it. But my mother rang me one morning and said, "Could you take me to the doctor today? We're going to do an advanced care plan." And I said, "Oh, well, okay, well, I'm not sure, but I'll take you." At that stage, they weren't driving. So I took them to the GP clinic, and they said, "Well, you can come in with us." And I said, "Oh, well, that's fine. I've got a bit of time. I'd like to do that. A bit interested." And I sat there with them, with Tim, who's a Barwon Health team member and does these advanced care plans, and talked through what was involved. And what was involved was really how, at the end, how would they like their end of life to be handled. And I wasn't quite prepared for that, so that's a fairly confronting thing for a son to sit there with their parents talking about the end of life, because they're both very strong, individual, independent people. I'll tell you their ages in a moment. But the plan talks about, firstly, the values of the person, what's important to them, and has a number of questions along those lines, and then talks about what the circumstances they'd like to see if they're in the situation, what would like to happen if they couldn't care for themselves. My father was very forthright and said, if I could not care for myself, if I could not do certain personal functions, and I'll leave that to your own imagination, what he said, and I have an incident, something happens that I can't look after myself, I don't want to be here much longer. And my mother's sort of response was along similar lines. And so the document was done, it was signed, it was witnessed, and went on to their file. And I guess I'd sort of had lost the sort of memory of it really as life went on. And a few years later, about 2.5 years later, Dad was clearly struggling a little bit with life. His eyesight was going a little bit, and his mobility was reduced. And we were spending a fair bit of time at home with him, just doing some personal caring with him. And we had good conversations, but he was struggling and he was a bit depressed probably. One morning we woke up to find him that he'd had a fairly severe stroke, and that he could not move. He was barely communicating, but he was still with us. And we rang the GP straight away and spoke to them, and we were able to organise for him to be admitted to a hospital. It was the St John of God Hospital in this case. And as Dad was being taken in, wheeled into the ward, the senior nurse there had a file, and in the file, top of the file, was a photocopy of Dad's advanced care plan. And I could not believe that. I'd forgotten about that document, could not believe that was there. What a fantastic system, where something done at Barwon Health in this community of Geelong we have was actually shared with the other health services in Geelong, and what Dad's wishes were laid out. And so we spoke to the palliative. First had the geriatrician look at Dad, and he looked at the advanced care plan. We began speaking about that. It was clear that his situation was one of palliative care, not of recovery. And we almost feel to the letter of the detail what Dad would like with his death. And for 3 days we were with him, and the sort of things he wanted music played, he wanted the family around, he wanted as many people there as possible, and a few times we had a room full of his many grandchildren and close family. And he died 3 days later at 98 and a half. And this was a man who lived all his life, built his own home, lived in the one home for 65 years, totally independent, did not like being dependent on anybody else, and was the thought of going to a nursing home where he was dependent on other people for his personal care and well-being was anathema to him. So we felt good that we were able to give him the death that he wished in that circumstance. As I said, my mother also did a similar thing at the same time, filled the advanced care plan with similar wishes. And a year later, Mum was in a nursing home, had accepted that her needs were such that she needed to be in care, and adapted to that life very well. But she got to the point where she had an infection, chest infection, wasn't clearing up with normal antibiotics. She said to her GP, I think that's enough. And she moved into a palliative care situation where he just didn't take any more antibiotics and was looked after, so she's made comfortable. And 24 hours later, she passed away very peacefully, again with the family around her with music playing. And so we were grateful that we had the advanced care plan in place, that we knew that that's what they wanted. They didn't want to be in a situation where they couldn't look after themselves properly. We as a family feel good that we're able to fulfil their wishes as much as possible. Mum was 94 and a half. But the message that I was given, and the message I'll probably share with you tonight, is that advanced care planning is not just for those in the later stages of their life in terms of long old age. It's for all of us, including me, because none of us know what's around the corner. A friend of ours, at 49, who would be known to some people in the room, got an advanced flu infection this year and passed away suddenly like that after a day or so in intensive care in a hospital. You never know what's around the corner. So I would encourage all of us in the community to embrace this concept, because it does give the family and those around, when the person cannot speak for themselves about what they wish, that our wishes are made known. So that's our experience with advanced care planning. Thank you.
Thank you, Keith, for those thoughts on advanced care planning. And I noticed Jill Mann in the audience from the advanced care planning team. I'm sure that would give you great heart to hear those things. I'd like to introduce Dr. Charlie Cork, or should I say Associate Professor Charlie Cork. Charlie is known to many here today. He is a senior intensive care specialist and occasional Apollo Bay medic. He is the current president of the College of Intensive Care Medicine and a lifelong advocate for end-of-life care. Charlie has spent much of his career staving off death including resuscitating his own dog with a chest tube some 20 years ago. Both Charlie and his wife have an agreement that neither will advocate for the other at the end of their lives, because Charlie would switch Ali off too soon and Ali would keep him going for far too long. I'm sure Charlie won't go on for too long tonight, but I'd like to introduce him now.
Thank you, Nick, very much. And I'd just like to endorse his comments about Jill and the advanced care planning service here. And Keith, thank you very much for those comments about it's nice to hear stories about how it's helped and worked. And I know we have a large number of people who do advanced care plans in Geelong, and I'm very proud of that and Jill's hard work in doing that. So it's been a big initiative. And my only thing is that we shouldn't talk about when it happens. If it happens, we should talk about when it happens, because it never doesn't happen. We have this if. If something bad happens to you in the future, the language is wrong. But I've been asked to talk to you this evening about my experience with voluntary assisted dying, or not really voluntary assisted dying, because the story I'm going to tell you wasn't really within the legislation. My brother and I were born in the early 1950s, and within a few years, our mother left. It was unusual in those days, and left us with our dad, and we never ever heard from her again. I don't remember her at all. I do remember the complete chaos, so that my first memories are of complete chaos at home with Dad when he was looking after us. It was sort of happy chaos, but complete chaos. And at the end of that, I can remember in a very Mary Poppins sort of way when my Aunt Joan arrived and sorted things out. I don't know if her picture's up there, is it? You can see that she's a no-mess sort of person. She was the first female housing manager in Hong Kong of the biggest public housing in the world at that time. There'd been some big fires in Hong Kong, the housing was terrible, and there was a big initiative to start building tower blocks in Hong Kong, and she managed the whole lot. But she came home to look after us, and it was wonderful. And then she went backwards and forwards to Hong Kong after that, having sorted things out and made arrangements at home. And we had a lot to do with her, and she was a very important part of our lives. So when she rang me and told me that she was in England, I was here, and she told me that she'd been diagnosed with metastatic cancer, I quickly got on a plane and went back to be with her. And it was a great time in that we had some amazing conversations. She shared some confidences and told me a lot of stories. And it was a very special time. She went on to talk to me about her fears for the future, and she had a lot of fears for the way this was going to go. And amongst that discussion, she showed me a little bottle that she had, and she called it her insurance policy. And I asked her what it was and where she got it from, and she told me that she wasn't telling me. And when she told me she wasn't telling me stuff, she wasn't telling me stuff. I don't know whether it was to protect me or whether it was just because it wasn't important that I knew or had anything to do with it. She did it all. I came back to Australia, and she died some weeks later. I've no idea whether she took it. But what I do know is that it gave her enormous confidence that she had control, in the same way as Rick's talking about. Having that control and knowing is what it's all about. And the evidence from Oregon is that not that many people sign up, and of all those people that sign up, not that many people go on and take it. But having the opportunity is what it's all about. And certainly for my Aunt Joan, that was what it was about. It was about asserting her control, and I respect her for that and understand that. And so my attitude to this is that, and I'd have to say, she got fabulous palliative care in the UK, and she recognised it as fabulous palliative care, and I recognised it as fabulous palliative care. So another point that Rick made, I would totally agree with. This isn't an either-or, this is a plus, plus, plus. That's what we want. So the decision about the end, we would like our end to be as comfortable as possible. Palliative care, please. And we'd also like to work out when we'd like to get off the bus. This bus ride's going to be bumpy and increasingly unpleasant. And the choice of when you decide to press the button and get off the bus seems a reasonable choice. Thank you very much.
Thank you, Charlie. In a minute, I'm going to ask for questions from the audience. And Kate, I wonder, do we have a microphone for our panellist as well? Before I do that, I'd like to thank all of our speakers for being so candid tonight, because it's not easy to share personal stories like this in front of an audience this large. So thank you very much for sharing those parts of yourselves, all of you. And I'd also ask you to be candid with the questions that you have to ask, because this is an important topic which has generated, as we talked about, a lot of debate within the community, and I'm sure many of you will have questions. There's some questions also that we've had sent in, and I'll throw some questions in as well. But perhaps I'd start off, Charlie, by asking you, you've been involved in a communication program about values at University Hospital Geelong, which I understand was involved in the Quality Awards last night. Could you tell us how this relates to the theme of a good death?
Thank you, Nick. The iValidate program that we've been involved with is designed to help doctors to have a conversation with patients, and we do simulated patients in the same way as Keith was talking about, very skilled simulated patients, to allow doctors to talk to patients about what's important to them and to give them that skill. And it's an important skill, and it's a skill that we clearly understand can be trained and can be improved. And it's been a huge revelation to us. In that the skill, how poor skills are and how much they can be enhanced. And it's a very important part of being able to deliver patient-centred care, and there is no greater patient-centred care than the care we need to give and the decisions we need to make as patients near the end of their life, and important decisions need to be made.
Rick, on that theme, what are some of the things you think doctors can potentially get wrong in this process?
They can project their own views. That's the biggest risk. In my practice, we initiated with Jill an advanced care process, and the first person who had the advanced care plan done in the practice was me. This was before I was unwell, and Jill did it for me, and just doing that improved my skills in talking to patients, because I'd been through it with an expert, and I got from mediocre to average after that. But most of the discussions it's very important, I think, to just show respect for people's views. Now, I occasionally come across people in advanced care plan discussions who want everything, and I think they're crackers. Absolutely crackers, but they do want everything, and it's their right to have everything, and it's useful for the health system to know they want everything. Because if I don't know about you, Charlie, but if I'm treating someone who wants everything and I am unsure that I'm doing the right thing by them, but if I know they want everything, I'll continue to do everything and not feel so bad. So knowledge about that is really vital. And but the main thing is, I think, is respect.
Well, I might ask for questions from the audience at this point.
Ask Keith one.
Certainly, Charlie.
There's a lot of talk that people don't want to go and do the plan. Elderly people don't want to do the plan. How did your parents feel about doing the plan?
Good question. They, I think they were invited to consider doing it by their GP, and I'm just surmising, putting a few things together. So I think they spoke about it amongst themselves. They knew at that stage, they were both in their 90s at that stage, they knew that clearly, as you said, there's a 100% chance that they're going to die at some point, and it's probably not that far away, and therefore they're realistic enough to think that we need to prepare for this, and with the opportunity that the advanced care planning provided, they could actually express their wishes. My father in particular, being that independent man that he was, and a fine man that he was, did not want to be cared for by somebody. And that was his great fear. He was probably more fearful of that than he was of death, actually, almost. And I think by articulating that in the advanced care plan, we knew when he then couldn't speak for himself at that point later on, when he couldn't speak for himself, we knew exactly that he did not want to be cared for to the point where he would just possibly end up in a nursing care with no quality of life, not being able to look after himself. We knew very clearly he did not want that. So I think this became an avenue for him to express his wishes in a way which we probably wouldn't have said out loud to us as family. In other words, they're difficult conversations to have amongst families. I know for the work I do with the Dignity Therapy Program that the conversations you can have with a complete stranger almost about these difficult topics is easier than having it with someone you're very emotionally engaged with. I think they went into this very willingly, and from our point of view, the family, it was a very enabling plan for us to follow.
Certainly, Rick. I'd probably just add to that point, Keith, that as an intensivist, it's an interesting point that once you get to these issues at end of life issues, the decisions still need to be made. So whether you have the information or not, the decisions will still get made. It's just that we know that relatives and friends experience quite significant post-traumatic stress and anxiety at potentially making decisions based on limited information, and indeed the doctors as well. So the more information you have about a person before these decisions come to light and they can't be involved in the process, the better it is potentially for relatives and for doctors.
When I made my plan, I was well. And my plan hasn't changed one dot since I became unwell, because the plan's about my values, about what I want, and it's not about particular treatments. So I would have dialysis if I was going to get off dialysis and go home, but I wouldn't have it if I wasn't going to go home. So it's what the end is going to be like that matters. And the only thing that changed in my experience was I was a little surprised that the conversation that I had with my children, when I did my advanced care plan, I re-had that conversation because it needed to be restated that I was in trouble. And one of my children got really angry with me and upset at my bleak attitude. And I said, I'm not bleak, I'm realistic. And he said, no, that's negative. And I said, I'm not negative, I'm not positive, I'm accurate. And it was a difficult conversation, and the reason it was difficult, it was because he didn't want to hear that his father was in deep poo. But I am, and therefore he needs to hear it. And it's fine, we've moved on, but it's not, I don't think the discussion is that hard. We are going to die, all of us, and that's a fact. You just have a straightforward discussion, and it should be done more frequently in our culture. There are times when it causes distress because the news is distressing. It's not the conversation that's distressing, it's the event. And then you move on.
And I think certainly some of the things that the junior doctors experience are significant worry about taking away people's hope. And what we try and reassure them at points during training is that the idea of many of these conversations is to strip away those layers of unrealistic hope. So then there can be realistic hope between the bounds of what is actually possible. It doesn't mean that all hope is gone, it just means it's a potentially more realistic perspective. Kate, there was a question there? Down the front.
Yeah, hi, it's Jason. Firstly, thanks to you three buggers for nearly bringing me to tears tonight. I just want to say thanks for your beautiful stories. It's courageous, but I also know that you've been a big part over many, many years, Rick and Charlie in particular. That's all right, Keith, and just what you've been doing in Geelong has been worldwide impressive, and it's just been amazing just to see the developments and just what's been achieved last week, and I know you had a big part in it. My question is more around the plan's done, and people, because bad things happen, will present to an emergency department, whether it's in Geelong or outside of Geelong. And the way in which the medical profession have been trained for years has been you just got to help it. You just got to keep going and keep going and keep going. How challenging has it been in a way too? It's good to hear that Keith's involved in regards to the Deakin students. So there's a new workforce coming through. But how unnatural is it for a doctor to respect the wishes of someone who filled out an advanced care plan when they were well, to respect the wishes when in fact you're in front of them, you're in crisis, and they're trying to help at all causes? Where's that at? And how do we also support our clinicians in overcoming and actually respecting the choices that you've actually made?
Patient autonomy does not mean patients do what you want them to do. So if someone's smoking and not taking their blood pressure pill, you respect that. It's not your role to force them to do it. The medical profession or medical system, the health industry, is there to encourage people to do those things, but not force them. So if people make choices you don't agree with, respecting autonomy means respecting their choices, whatever they are. And I personally don't find that very difficult at all, because all of us do stupid things, and I don't want someone telling me what to do. So I don't feel any qualms about letting people do whatever they want to do, as long as I am, in my professional role, informing them of what their risks are, seeing are there obstructions for them doing silly things, are there things that we can help them with, but our role is how can I help, not you must do or should do. The how can I help you is really the major role we have to play.
And I'd agree with all of what Rick just said. This is really what we're doing in the course, to try and make doctors understand the patient and adjust the recommendation for treatment accordingly, rather than doing everything. We know that doing everything always gets you into trouble in the end. Knowing when to stop is the art of medicine, and it's what we're trying to do. I'd also say that the new Act that's just going to be brought out in Victoria, 2016, they tidied up the Advanced Care Planning Act, and it's coming out in March of next year. And the fundamental of that is moving from a concept of doing things in the patient's best interest to actually overtly saying doing things that are consistent with what the patient wants. And it might sound a subtle change, but it's a major change. And we have to justify to those who are auditing what we've done, that we've done what we believe to be in the patient's best interest. I think that's a very good move for Victoria.
I think there was a question over there, Kate. Yes, certainly.
Just if I could take a moment in the interest of sharing, I've lost both my parents in the last 5 years, two very different scenarios. And I won't go into a great level of detail, but my father had prostate cancer, was of the generation that when you go to a doctor, he's too busy to deal with whatever's wrong with me. So he doesn't have time to listen to my concerns, to my questions. So I tried to counsel him on the fact that, you're the patient, you're the important person in the room. Palliative care, don't need that, not dying yet. Come the day, Christmas Day, he was sitting there looking at me going, there has to be a better way to die. And 6 days later he did. But the situation is we weren't able to have that conversation with him because he wasn't ready. Who is ready? When do we have that conversation and how do we manage it?
Charlie.
Well, I think we have to listen for patients to be ready. It's always sad if patients are never ready. Never dying means you never say goodbye and you never put anything right and you never have palliative care. So all of those things in my mind are losses. And the description you give is a very classical description of a man who doesn't accept it and isn't going to die. So community education is a good part of this, an important part of this. Changing the community and changing the doctors is necessary to make this better. And of course, having systems that are able to deliver what we need. But thank you for your story.
Keith, did you have any comments on that? And given, I did have a question for you. This is from the community. What about after someone has died? Is there support for family members left behind? How was that with your experience?
I guess, well, every person's experience is different in that regard. I guess it's all about connectedness in the community and the people who surround you at that time. In our experience, that was strong with our parents who are both well connected in the Geelong community, very active in the community. But I know that's not the case for everybody. Some people feel very alone in grief. I'm a board member of Hope Bereavement Care, and which was started by Dr. Bernie Jenner almost 30 years ago, working with families who lose children, and our vision is that no one will be alone in grief. And we have support groups, counsellors working with families who lose children. Over the years, that our vision has expanded to work with people who of an older age group, particularly people who lose families who lose children or family members through suicide. And we're now working with Support After Suicide, which is sponsored also by the Jesuit Social Services in Melbourne. So in Geelong, we're gradually building, I guess, a bereavement network that is positive, you know, for a community like us. At the end of the day, it's the ongoing support of family and friends that will sustain people in their grief. I think and you can't really legislate around that. It's something that comes, I think people sharing their experiences, just like we've heard tonight, people sharing experiences like that is so powerful, because you realise that we're all in this together. We're all going to we're all going to experience losing someone close to us at some point, and we're going to go through that ourselves at some point as well. So I think talking about it and enabling the conversations, as you were saying before, Rick, having the conversation is certainly what's the word? Lifts the burden that sometimes people are carrying. And I know, again, reflecting back on my work with Dignity Therapy, the fact that people can talk about what's important to them and their values, and what they've learnt about life, and to have someone hear that and record that is another part of that process. I think you were saying before, Charlie, about recognising we're going to die, maybe setting things right, saying the things we need to say, saying goodbye in the way you want to say it. They're things that our society has generally shied away from and we still struggle with, but the more we can do that, the more, I guess, the better death we'll all have. I'm not sure that probably doesn't answer your question, but...
No, it's very relevant.
I say it's not all doom and gloom. I played the cancer card so hard over the last year. I've got all these things done which I wouldn't have got done before.
Can you give any examples, Rick?
My 3 older boys I hadn't spent Christmas with for 20 years, so now they're coming.
Fantastic. Yeah. Yes, please.
Hi. My name's Deb. I am a GP, and I've been very interested in following the course of the legalisation of this current bill. And one of the things that was discussed with me by colleagues and non-medical people was how can doctors feel comfortable in participating in this assisted dying when we're taught to respect life and do no harm. And I actually looked up the Hippocratic Oath because I wanted to read the wording, and interestingly enough, it has been modernised in just recent times, like this year. And the current wording is to respect human life, But under that, it says to respect patient autonomy and to respect patient dignity. And I just thought, well, that's perfect, because that's exactly what we're doing. And I think people get the idea that doctors are going to go along with this enormous syringe and, put it into this IV line and that's going to be it. It's not actually the doctor that's going to be administering the medication or the drugs involved, unless the patient is incapable of doing it. And it's all about patient autonomy. It's their choice. It's doing it when they want, under circumstances that is comfortable for them.
Did you want to comment on that, Rick or Charlie?
Yeah, sorry, it wasn't really a question, but I'm happy for you to comment.
That's a good note.
I think you're right, Deb.
Yes, please.
Could I add something to that? I'm at the pointy end of things. I'm probably a lot older than even Ken, Keith. But one of the things that does come about is that we're looking for quality, not quantity at this stage of life. Like Rick, I had a stage 4 bowel cancer 6 years ago, and the oncologist last year said, I'm scared to use the word, but I think you're cured, which made all the dramas and so on that I went through for 12 months well worth it. But, I'm looking to the future now, and I don't want any more chemotherapy if anything goes bad. As I say, I want quality, not quantity.
I might just pick up on a couple of those things, because you say you might be more at the pointy end, but we never really know, do we? I used to have this friend in Western Australia who said, enjoy yourself, it's later than you think, and he certainly did. But the other point is that we've been doing some collaborative research with Charlie and his group, and we've asked a lot of people what they think in particular about values and the relationship to the end of life. And many of them feel as you do, but some of them don't. Some of them actually see longevity as a single goal in itself as well. And Rick alluded to that before. Some people you may think are crackers from your own construct, but people think differently, and it's important for us to respect those wishes when we're at the pointy end of their treatment.
One of the things that you just mentioned then actually strikes fear and terror. This whole idea of increasing longevity. We were only meant to live for so many years, and after that all our joints start to fail, and particularly if you play sport and that sort of thing. We've got all these adjuncts that we're adding into our life now, like chemotherapy and advanced surgery and so on, that are keeping us alive a lot longer than we were expected to be kept alive 20, 30, 40 or 50 years ago. And we have the people who have chronic illnesses that are made more and more aggressive by the longevity that we are living through drugs, medication and good treatment by our doctors. But it doesn't get rid of the underlying chronic illnesses that some people have that are more debilitating than cancers and so on in their later stages, but they're not covered by this new bill. And that's an interesting thing. You've got the people with acute osteoarthritis, arthritis, all those other things that can't be treated in the long term successfully, and what happens with them?
Charlie?
Well, just pragmatically, I just answered that we're the only state in Australia that's got the bill. And if any of that had been in it, we wouldn't have the bill. So we've got to, if this is true, and if what we're talking about is reasonable, you've got to start somewhere, and you're better to start at the far end. I'm not sure. I don't know that there's that many people. There's not many people that take it up anyway, and I'm not sure that arthritis is going to, osteoarthritis is going. It's frustrating, but so I think where we've started is I feel personally comfortable that where this is set.
Yes.
I've got a question about terminally ill children and how's that processed, and particularly with respect to the rights of the parents, I guess, but also the autonomy of the child. Do you have any answers around that?
Well, nothing has changed with this Act from the point of view of children. Parents continue. There's a slight change in the Act that's coming in that older children have more chance to be listened to, where the parents are taking a different attitude to the child. It's very complex, though. No, that's the Medical Treatment Act. It's very complex. And you can understand why it's very complex. There's enormous emotions involved.
So perhaps I could ask all the panellists on that note, how do we go about normalising this conversation for people within the community so that not everyone may want to talk about it, but those that do feel that they want to feel like it's a normal process that they're able to go through?
Charlie had me the mic, so I'll start off. Thanks. Recently, I took part in a death over dinner exercise organised by Kate, I think, and Neil Orford was the host of the dinner, of the lunch we had around the table. And I think there were a few people who might have been there, and it was really. And I was a bit sort of uncertain about it, but actually the process was that we began talking about what's our favourite music, or what would you like to be played at our funeral, or what are the important things have you done in your life, and just gentle questions like that began to open the topic. And then I think other questions went into, well, have you lost someone close to you? How did that feel? You know, and the conversation ended up being quite full and frank, very funny, mostly lots of laughs around the table, and was a really good conversation. And it ended up about how we'd like to see our own death, or what we'd like to see at our own funeral. Who wouldn't you want to be there, or who would you? Things like that. And I think to answer the question about, I think we need to be just. In this more enlightened society, if you like, society where even people like me, men, blokes, begin to talk about their health and talk about how they feel and talk about what's ahead, feel more enabled to speak about these things and have a conversation. I think it's a societal change, but I'd really, if ever you're invited to a death over dinner exercise, please go along. It's not as daunting as it might seem, but I think they're the sorts of proactive things we need to do to actually get this topic out and about. And I think the most recent legislation and all the talk in the Parliament about that has brought stories out, has enabled people to talk about it in the community a lot more than perhaps we would have otherwise as well. So it is a progressive thing, and I hope we can, as a society, continue to do that in an enlightened and informed way. It's not a morbid topic; it's actually a life-giving topic.
Thanks, Keith.
I'd just like to extend from that my observation. I mean, we're a bit weird, and we talk about this stuff. So, at Christmas dinners, we talk about it, and I've observed that no one in my family goes, I would want to die in a nursing home with a trachea and a peg tube. All right? So why, when we're in the hospital, is everyone saying, of course he'd want a trachea and a peg tube and go to a nursing home? So there's a huge divide between the community attitudes and discussions and what we do in hospitals. Why is that? Is that all just the doctors? I don't think it is, because the same relatives are going, you must put a trachea in my elderly dad, and it's awful. So that's what I think. So we do need to talk about it. And the other thing is just understanding, just get that reality. People have got these thoughts, get them down and let's share them. And my final thing would be, it's so much easier to do this wildly early when you're completely well. It's no challenge at all. And then you can just sort of like tweak it as time goes on. But, you know, I'm impressed as well with what Rick says, that people don't really change it. So when people come in with a good plan, I get it out and say, that's what you said. Does that stand? And almost always people say yes. So it's easy.
Can I just add to that there's a whole lot of language issues in health that we use, and there's this idea of the noble struggle. So if you battle, fight, war, struggle, all those military terms. So if anybody here comes up to me and says, oh, you look so well you're in your battle, fight, war, struggle against cancer, just watch out, you'll get an earful. It is not a battle, because battle means that you've lost, and it means that it's somehow people think that if you have a great attitude, you will live longer. That is crap. You will not live longer. You will live better if you have an attitude to living your life and enjoying your life and being reasonable and realistic. But if you think that your attitude will make your cancer go away or your MS disappear or your motor neuron get better. So when I watch the motor neuron thing and I hear the commentators talking about Neil Danaher's struggle and what a great fighter he is, it makes me want to vomit. And I think we should be very careful about the language. There's a fantastic book written by Susan Sontag in the 1980s or 90s. It's called The Metaphor, Illness as a Metaphor, and it describes this beautifully. And it's cruel to tell people that, because it means that when they get sick, it's their fault. They didn't try hard enough. And we are going to die. We're all going to die. I'm going to die probably before some of you, maybe not before all of you. But you just got to get on with living until we do.
Thank you, Rick. I might take one more question.
Yeah, we have a question from the Facebook community, and it's from Para Pahir. He's sort of speaking from a perspective, the fact that there are some cultural issues with families families talking about end-of-life care, and perhaps some suggestions on to how you would address that, particularly with the Tamil community.
I think this gets straight to the point that it's about the person. So community, other ethnic, Australia is becoming increasingly ethnic, multicultural. We need to understand all the different cultures and have this conversation. And all it is a jack up of the complexity of the conversation about how do you think, how do you conceptualise things, what's important. And it's important that across religions, there aren't many religions that think that real suffering is really magic. There are some. I don't ascribe to any of those. But most religions do not believe that suffering is really ennobling and really wonderful, but some do. So you've got to listen to that. So it's just about the necessity for us to listen on an individual basis. And, culture, I asked Monsignor Murray some years ago about the Catholic attitude to something, and his answer to me was, which Catholic?
I'd agree with that, and if you assign a value to an individual based on their culture, you're likely to get it wrong. There's more spread within a culture than there is from without the culture. So you may find that one Tamil's view is different to another's significantly, and you can't assume that the culture will determine or drive their views. You have to explore it, and it's the individual's views, not their culture's views. And often in the past, I've had looked after people from Eastern Europe who have had cultural stuff that has been difficult for me to understand. But the individual who I'm looking after has often had to struggle with the rest of their family trying to force some cultural thing down their throat. So you support the individual, whatever their view is, that's your role. You're not the culture police, you're just there to help. How can I help you? What can I do for you? That's all we have to ask, and that's what we have to do.
I might sneak in one last question for the panel, and it's from the community once again. But you mentioned the interplay between this legislation for voluntary assisted dying and palliative care and how they're not exclusive concepts. But this question is one that we do hear commonly. I've heard that it's difficult to access palliative care services, that there are waiting lists. Is this true, and what are the options for me for palliative care? Got some expertise in the audience.
Hi, I'm Jackie. I'm the Palliative Care Program Manager at Barwon Health. So the question about access to palliative care, certainly palliative care at Barwon Health, we're really fortunate. We have an integrated palliative care service. So that means the UHG, we have the consult team, community palliative care and the palliative care unit. We actually don't run a waiting list at all for the community palliative care program. So essentially referrals are assessed and triaged on the basis of need. Sorry, I need a drink of water. And for the palliative care unit, sometimes there is a waiting list, but I guess again that's prioritised, and we endeavour to get people into the palliative care unit as quickly as we can if that's where they want to be. Does that answer your question?
Thank you. We're lucky to have you in the audience. Look, I might close out the discussion at this point, and I want to thank all our three panellists, as I said, for being so honest and sharing their stories. But equally much, I also want to thank you all for sharing your stories and asking such insightful questions as well. As you can see, there's been a lot of emotion in the room, and this is a topic that does generate a lot of emotion, but equally it affects us all. And I'd like to say that if you have been affected by the conversation tonight, that you seek out someone that you trust, up to and including your GP, and you may like to talk about some of these concepts, or you may even like to talk about advanced care planning. But what we've just done here is to have a normal discussion about death and dying, and I thank you for taking part in that. And I'd like to hand back to Brian and thank all our panellists and our audience.